Selamun Aleyküm. It's a great honor and privilege to be here. I appreciate my dear friends, Mohammed Albora and Mohammed Amer. I think Mohammed Albora already gave it to my wife for that lovely gift. Thank you. She's happy with that. And let me give all the poses and become a very popular guy, then I'll continue. Okay. Now, we discussed what to talk. I'm going to talk with you a potpourri. That means I'm going to mention what was the latest achievements the last year in the field of reflux disease. Reflux is my third kid. According to the family, it's my first kid, but still there's an ongoing debate which one comes first, reflux or kids, but I love the reflux for sure. And let's start with the new definition. This study came a couple of weeks ago, Lyon 2.0. Lyon 1.0 was about the definition, and even though I was a part of it, I was so much confused because you see, this is the conclusive evidence for reflux. What it is, LAC&D, or long segment Barrett, or peptic stricture. My friend, how many patients you have getting into this definition? Just a few. Or acid exposure time is higher than 6%. How many percent of patients? Just a few. What is normal? Normal is this one. Acid exposure time less than 4, and number of reflux episodes less than 80. The rest is, we don't know. And at least 80-85% of my patients are in this borderline. And in this borderline, there was something difficult to believe, histopathology. We just published a study showed that histopathology is worthless in terms of the differentiation of reflux phenotypes, hypersensitive or others. And also, the others didn't work. I will show you right now. This is the version 2.0. Version 2.0 made things a little bit easier. Now we have, at least they put something in front. They took something from inconclusive, put it into the conclusive one. Now life is a little bit easy. But if you are doing all the diagnostics, the problem with the Western guidelines, they assume everybody does everything, full with the whole world, full with motility, impedance, and everything. But this is not the real life, as we know. When we look at that, at least they put the esophagitis B inside the definition. Okay, not bad. And others you can hear. Acid exposure time is still the same. Mean baseline impedance is a metric which can be measured by 24-hour pH impedance. As we have been discussing for 2 days, there is a strong need. I know Egypt is so much powerful in liver, IBD, endoscopic procedures. I think it's my 4th visit here. I'm so much impressed. But there is still an unmet need for functional GI disorders. And I'm calling, guys, please go ahead, involve more to the functional GI disorders diagnostics, specifically anorectal motility and constipation and incontinence. There's a huge unmet need over there. There are just few centers. In Turkey, there are only 3 centers dealing with the anorectal function test. Good centers, some of them doing supposedly. That's something else. Anyway, and there are some conclusive metrics, but here, the point here is, if I have a patient with unproven GERD, first thing I try PPI, that's for sure. So single, even double dose of PPI. And then if they don't respond, still I have a suspicion. Then for this Lyon, they push a lot the wireless pH monitoring. That's a little bit tricky, very expensive one, or to a catheter-based mechanisms. In the other way around, if we have a patient with previously proven reflux disease, but do not respond to PPI, then we perform all the tests, including endoscopy, on PPI. Because if you have a patient, and you clearly ask and learn that patient not responding to PPI, in that case, put him or her on PPI, repeat on your endoscopy, and see whether there is an erosion or not. And there are different parameters, but I'm not going to go all over again. This is one of them. They put LAB, which I'm so happy now. And also this Bravo capsule pH monitoring getting more and more important. I'm not sure how important it is. It is important. It's very expensive. Hundreds of euro just the catheter. Hundreds of euro. 300 euro just one cat. But that gives an opportunity to measure a longer time frame. And you don't need the motility in order to put this while the patient is still on the sedation. During the endoscopy, in the endoscopy room, I put this capsule and I can measure all days. And I download, in my style, I download every day the data and look whether it's pathologic. I immediately start the PPI therapy. In one occasion, I diagnose the pathologic reflux, and also I see the PPI response, two things together, which is very much useful if I tell the truth. Anyway, there are many things change from Lyon 2 to Lyon 1, but what we learned that now we have less restricted diagnostic criteria. When we see an sometimes I see an esophagitis B 2 centimeters long, maybe it's not reflux. Come on, that was not the case. At least now it's in the definition. At least now we know that we should prove the reflux disease in patients without responding to PPI with some further diagnostics. And I think this is the most important achievement. We have been discussing yesterday about that. I'm a part of this study. I'm the Turkish PI of ROM4 epidemiologic study. It's published in 2021. I'm not going to talk about that one. Egypt also is a part of it. What we show that it's an internet-based study and also household. Turkey is one of the countries we perform internet and household survey together. But the point here is there were 73,000 people. Wow, it's a big one, 73,000 people in general. And we have about 40% of any type of functional GI disorder. Anyone, any of those, between 22 subgroups. Very high level. But this study just came out. They look at the clinical relevant distress or somatic symptoms according to the countries. Remember, clinical relevant. This is important. Sorry for the bad table, but this is the original ones. It's still ongoing. Okay. The lowest value goes to Forest Asia and the Netherlands. Again, clinical relevant, anxiety, depression, or somatization. World record goes to Egypt, 60%. But we in Turkey, we have the world recorders of somatic symptoms with 55%. This is very crucial for you and for us. I knew that. Majority of my patients actually comes with psychiatric comorbidity. I became a psychiatrist since I'm dealing with functional GI disorders. And we have been discussing this for a long time with the Western scientists. They say, you are exaggerating the psychiatric problems. Now we realize that we are not exaggerating. The message, my friend, if you have a patient with any type of functional GI disorder, please keep in your mind that there is a very high possibility for having any type of clinical relevant psychiatric problem. This 55% and 60%, yours and ours. Remember, those are not the patients. Those are the people around walking on the streets. When we look at the patients group, they didn't look at it. I strongly believe it's much higher, much higher. That means at least, I'm estimating 7 out of 10 functional GI disorder patients coming us have clinical relevant psychiatric comorbidity. And that's also increased the importance of using neuromodulator such as amitriptyline, which I love the amitriptyline and I use it a lot. How about the anatomical problems? In the esophagus, odds ratio is 6 times higher if patient has clinically relevant psychiatric problem. Reflux plus psychiatric problem, 6 times more. Number of places, how many places affected different organs. You see, let's say patient has 3 different gut-brain interaction problems. Odds ratio is very high, 18. This is one of the example.
Daha çok oluyor. Yani birisiyle konuşurken daha çok oluyor.
I see it every day, nearly.
Ağzınızı kapatın.
This is a very typical patient with typical somatization disorder, anxiety, whatever, aerophagic and belching. And this is not our patient at all. Let's make it clear. This is a psychiatric patient. Then that's the message. We see a lot of psychiatric patients. Okay, alginate. That's the alginate. You know, alginate is a seaweed. It's produced from the sea. And because of the climate change, alginate is disappearing, even though companies don't say that. And this is the only endoscopy I recorded years ago in order to show how the alginate produced the raft here. When we eat something, my friend, food accumulates here. On top of the food, we have acid. We call it acid packet. When the reflux occurs, that acid packet comes up first. Even after the food, we have acid reflux. Not weak, not non-acid reflux. And the alginates produce a raft here on top of it. And we measure it. We put a pH catheter, when we pull it up, and we measure, first time in the history, alginate and PPI, what's happening. This is before alginate, stomach acid. This is food, pH up to 7. Between the stomach and the esophagus, you see the acid packet. When the reflux occurs, this one goes to the esophagus. When we give the alginate makes the acid packet smaller and increase the pH inside the acid packet. We know that. But what we don't know is the effect of PPI. PPI already demolished the acid packet and produced weak acid. When we add alginate on top of it, then we have very high pH, 7, 8, whatever. Why it's important? Because in patients with LPR, laryngopharyngeal reflux disease, or chronic cough related with reflux disease, they are very much susceptible to the weak acid and non-acid reflux episodes. If I drink the water and if I aspirate it, I cough. If I aspirate my own stomach juice with a pH 7 point something, then I cough. This is why it is important to combine PPI with alginate in patients with atypical reflux symptoms such as hoarseness, cough, or laryngopharyngeal reflux disease. As we discussed, this is the potpourri. I'm touching different things. I think one of the most important questions is this one. Does PPI kill the people? I don't care the side effects. The final endpoint is the killing the people or not killing the people. And a lovely study came from United States of America. You know, they are so important guys. This is why killing is pretty crucial here. And they look at the PPI-related mortality rate. 1.9 million seniors. Those are elderly people. When you look at the numbers, yes, actually, PPI killed the people. Look at the odds ratio here. Yeah, killed the people. However, the problem, please, when you read something about the PPI side effects, always ask the simple question. Is there any lag time? That means, let's say we admit a patient to the ICU. All of us start PPI. Or with a severe patient. Everybody start PPI. Then the patient dies. And someone years later look at the retrospective data saying that, oh, patient died because of PPI. No. Patient died because of other problems, but we, doctors, love to put them on PPI. This is why all the new studies related with PPI side effects are coming with a lag time. Lag time means they don't look at the 90 days before the death, they look at the before that 90 days. And when we look at that, when we look at the ever on PPI, PPI kills. Or very, limited effect. But funny enough, short-term PPI mortality is significant. You see 1.29, even with the lag time, short term. That means I give the PPI my patient 5 days and I kill the patient. Come on, I don't buy this, because when we look at the long-term PPI, actually PPIs are protecting, decrease the mortality. Is what I would love to see that, which I believe that. And H2 blockers, yes, there is no risk for H2 blockers as well. And I believe this is the most important data. Long-term PPI consumption, after a lag time, PPIs protect against the death. Then PPIs don't kill the people. Other effects also very much debatable. Currently, what we believe, if there is any side effect related to PPI, such as osteoporosis, we don't stop the PPI. If it is needed, that's the question, but we treat the complication. And this is what we say, the summary of what I am saying. I saw too many booths out there with Prosans. Then I thought, Alboray, okay, let me put something with Prosans. We don't have it in Turkey, because they are expensive, and nearly 95% of the people, the population covered by the governmental insurance. In that case, government never pay for Prosans. But I wonder what happened. This is a lovely, pretty new network meta-analysis. We have randomized control studies, we have meta-analysis, on top of them we have network meta-analysis. Okay, this network meta-analysis compare vonoprazan with PPI with many different ways. Result day 1, day 7, cumulative day 1 to 7, blah, blah, that way. What they show, heartburn resolution, I'm going to go them quickly. Vonoprazan 20 milligram looks in the short-term effect and in the long-term effect, it looks like for those patients, heartburn, and also there is another recent network meta-analysis showed that for erosive esophagitis as well, Prosans look better. And this is the, I think SUCRA ranking is pretty important. Heartburn resolution day 1, the highest value is 1. 20 milligram is the highest one, Prosans. Then we come the esomeprazole 40, blah, blah. When we look at the day 7, rabeprazole is similar with vonoprazan. Still vonoprazan is number 1, and rabeprazole is number 2. Interestingly, pantoprazole is the lowest, and the others comes later on, according to the SICRA study. But remember, we are now writing spasmolytic agents, expert opinion for Turkish Journal of Gastro. I collect all the meta-analyses related with spasmolytic agents. Each meta-analysis take another reference. There is no relationship between one meta-analysis and other one. That means people are playing with meta-analysis as well. They are accepting some of them, they are refusing the others. We cannot control. I think network meta-analysis is the highest level of the evidence-based medicine, no question. Still, we should be cautious when we interpret the data. This is the lovely study, Icarus study. Is there any surgeon? No surgeon. Mohammed, we can say bad things then. Yeah. Okay, this Icarus study is about, I'm a part of it. This Icarus study is about the endoscopy, the anti-reflux surgery indications. That's an international consensus group. Okay, let's start with I'm coming from this anti-reflux surgery. Then I'm going to move to the endoscopic procedures. Who is a good candidate for the surgery? Everybody thinks that if patient doesn't respond to PPI, he should go to the anti-reflux surgery, which is completely wrong. The best patient is the best responsive, specific the heartburn. Then why I'm sending to the surgery? Because I don't want to keep my patient on the PPI for 20 years. I got the anti-reflux surgery by myself. I'm so happy. I ate all the lovely kebabs yesterday night without any problem. This is why. Those are the indication. Hiatus hernia, paraesophageal hernia. Barrett, we used to say it's not an indication, but at least there are two good meta-analyses show that anti-reflux surgery decreases the risk of having dysplasia in patients with Barrett. Not the short one though, maybe the long one, but this is also an indication. And also those two, please, 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 never send them to the surgery. Functional heartburn and eosinophilic esophagitis. Dear participants, any patient with dysphagia comes to you, when you scope the patient, please, please, please take the biopsies for eosinophilic esophagitis. 4 from distal, 4 from proximal. Without taking the biopsies, we cannot prove anything. And EOE was not exist in Turkey about 10 years ago. Now, wow, it's increasing like hell. If I have a young patient with a dysphagia, first possibility is EOE. And Icarus says that, which I totally agree, before the surgery, endoscopy is mandatory. No need to take the biopsies except the EOE. Barium X-ray for the size of hernia in the world of high-resolution manometry. High-resolution manometry is the gold standard for the detection of hiatus hernia. Not endoscopy, not surgery, not barium, but the motility. This is why all the patients must go to the manometry and 24-hour pH impedance before the surgery if you have the opportunity. That's very important. And in our practice, we have a huge reflux team consisting of gastro, ENT, pulmonary medicine, general surgeon, and the most important person is psychiatrist. Everybody was laughing at me, why you include a psychiatrist in your reflux team? But the study I just showed you, if Turkey is the #1 in the world for the somatization disorder, I need a psychiatrist in the team. And we always invite the patient inside the room while discussing everything. Then we look at the patient, so psychiatrist, if psychiatrist does this, we never touch the patient. Surgeons never touch them. Somatization disorder and anti-reflux surgery is a nightmare. How about anti-reflux procedures? We have different procedures. Stretta, I love it. I've done it many times. Very safe, less effective than the others, but it is a transition between the PPI and the surgery, even though I will show you some debate still exists. Ozofix and GERDix. GERDix is getting more and more fashionable nowadays, but those are the most common procedures. Soon, GPs and obstetricians will start to doing that. Everybody is doing arm and arms. I've just seen a girl in Turkey, 17 years old girl with rumination, very typical rumination. They say, without anything, they say endoscopy is normal. Okay, we should perform ARMA. Should nothing change. Rumination is a psychiatric disorder. Poor girl, we did everything. She doesn't have reflux at all. There are many, many different endoscopic procedures. Okay. And this is GERDix. Here we have Stretta, we have ARMA, we have ARMS, and we have LINX. LINX is out of this discussion because it's a surgical procedure. I recommend Stretta, even for the hypersensitives, even though results are conflicting. Easy to do that, but it's expensive. But also the complication is too low. GERDix, yes, it is indicated in very well selected patients. ARMA and ARMS open to the debate, very much open to the debate. I was a reviewer of United European Gastroenterology Week. There was a study from Japan looking the long-term effect of ARMA. And that was poster discussion. I went and I listened. The guy claimed that ARMA is so much effective even with the diagnostics. They put pH and everything improved. But when we read the data, before the ARMA, pH was 94%. That means they put the catheter inside the stomach. Even they didn't know the catheter is inside the stomach. And then they repeat it after the procedure. They put it in the esophagus, all normalized. We were shocked. I mean, if you are doing something, first you should know what you are doing. You cannot put the pH catheter inside the stomach and saying that, wow, there is a lot of acid here. Still debatable. How about the studies? This is the first systemic review of a network meta-analysis of different endoscopic procedures, STETA, TIF, and PPI. In terms of short-term reduction of quality of life, TIF is equal to STETA, and both are better than PPI. STETA is good for the quality of life, and TIF as well. Reducing the acid exposure time, then PPI is equal with TIF. Don't forget, PPIs don't change the number of reflux episodes, that they only change the nature of reflux state. If you are taking a PPI, you are still refluxing, but it's less acidic, or weak acid and non-acid. This is why patients do not feel the heartburn. And in terms of PPI utility and esophagitis, TIF is equal to STETA. For the less pressure, as expected, TIF is better than both. Reducing the esophageal exposure time, STETA is better than TIF, but with a question mark here. And for the long-term comparability is not possible because except STETA, there is no long-term studies. Also, this one just came out. This is another, you know, Chinese love to write the meta-analysis. There are too many meta-analyses from China. This is the one of those. And they compare different modalities. But here there is a trick. When I look at this reinforcement of less, they put 3 different modalities in one group, which is not acceptable. Then I only accept TIF versus PPI, STETA versus TPI results, not the rest of them. In terms of requirement, the PPI continuation, STETA barely missed the significance, but the others, TIF is pretty good for the requirement of PPI continuation. Really, patient on TIF needs less PPI. In terms of the quality of life, then, and the requirement of PPI, sorry, this is the quality of life, this is the requirement of PPI, this is quality of life. Quality of life is better with the both STETA and TIF. Arms is lovely. Everybody can do that. This is what we do every day. Many endoscopies. Safe, feasible, okay? No, it's not new. No need to expensive specialized equipment because that's with the routine techniques we can do that. But we don't know the long-term results at all. Even we do not have objectively proven efficacy studies. That's a big problem. I don't think we should put our patients in a risk without the extensive diagnostic pre and post modalities. This is the only study, as far as I know, with ARMA, preliminary one, they already say that, and they said that barely effective, but it's a new study, and what they conclude is this endoluminal and minimally invasive surgical devices are promising, yeah, totally agree, but their place in the treatment algorithm will be better defined, and especially, very importantly, durability of the effect. If you look at your patient within the 3 months after a procedure, there is always a placebo effect. How about the long term? Then we need 1 year, 2 year, 3 and 5 year results, which doesn't exist anymore. Mohammed gave me this talk. It was 2 years ago, 2022. I gave it online. And that was my last slide. Still, I agree with my last slide. Is it a myth or is that reality? Endoscopic procedures, my friends. Not a myth, but not a true reality so far. Before you perform it, please think twice and please check the patient with diagnostics. We should wait and see. We need very carefully selected diagnostics. This is why having the esophageal function tests are pretty important. It shouldn't be abused. I know in my country, people abuse the technology. Not everybody, but people abusing the technology. In my center, without objective diagnosis, we never do that. And if I sit over there, I'd rather to wait and see for the future studies for that. It was a potpourri. I tried to touch different things. Thanks to Mohammed Al-Borai visiting my center, this is the 2 different equipments. And also, you see these guys, they are all, Mohammed Amir, where is he? I don't know. Oh, you are here, okay, you run away. As they mentioned yesterday, we had lovely workshop. I love it too much. Anyway, my last slide is this one. I'm coming back in your lovely country next month, giving 2 lectures in treating GERD and also treating IBS. Treating IBS is something else. Too many unscientific data exist about the IBS. This is my email and my mobile. If you want to get any type of education for motility, third space endoscopy, or ERCP, I'm sure also it exists in this country as well, education centers. You are always welcome to Ege University. Again, thank you very much for the invitation.
It's not yet recommended by the American guidelines, by the ECG guidelines, because the results are not usually consistent in every patient. Some patients improve, others don't. And you say it's effective. Do you think we should start here in Egypt re-evaluating this procedure? Yes or no?
Let me, not yes or no, there's a maybe there. Yeah, AJ doesn't suggest it, but SAGES, surgeons suggest it. And if surgeons suggest it, that's important. Studies with Stretta very much conflicting. Some studies show a very beneficial effect. Some studies show a very negative effect. Yeah. And there are 2 meta-analyses. One says very effective, one says no effect at all. Come on, I don't know which one to believe. I believe my humble own experience. About 55 to 60% of my patients are not using PPI anymore or with lower dose of PPI. And it's very safe. I have no problem with any patient so far. What I am suggesting, since this is a very safe procedure, I tell the patient, if you have money, if you want to waste your money, if you want to risk your money, let me do it because it's expensive. If it works, it works. If it doesn't work, you go to the surgery.
Yes, you are right. But for each procedure, I mean endoscopic procedure, there is a problem. With TIF, the problem of bleeding. It's very expensive, transoral incisionless fundoplication. It's very expensive, and the problem of bleeding is heroic. The other problem with the ARMA. ARMA is a very cheap one. Everybody can do it, as you said, but recurrence is the problem. It's usually there is high rate of recurrence.
But there is no data. That's the problem. Yeah. I mean, people keep doing it. People just burning the esophagus, the cardia, but they don't know what they are doing. They have no diagnostic. They have no follow-up in majority of the patients. That's the problem. I'm not saying that it's good or bad. I'm saying that we need long-term control, sham control studies. For GERDix and for Stretta, we have sham control studies. But ARMA and ARMS, I'm not aware of any sham control, if there is one exists.
Thank you again for your lecture. I will ask 2 questions if I will not delay you from the flight again. If we have time, I can ask Dr. Amir. I have time. Okay, my question, first question, the role of anti-reflux surgery in a patient with esophageal dysmotility. Is there any rule for the anti-reflux surgery or any complication after doing the surgery? The second question, the role of banding without mucosectomy.
Thank you. Should we perform motility before the surgery? Of course. I see a patient perform Nissen with achalasia or with scleroderma at least 3 to 5 cases a year, because the surgeon didn't ask for the motility before the surgery. This is number one, why we should perform motility. Number two, does surgeon tailor the surgery according to the motility findings? We have some patients, no peristalsis at all, absent, claim still it's reflux, not achalasia, not scleroderma. We have patients with ineffective motility. We have patients with ineffective motility, but very well reserved esophageal peristaltis. Those are different subgroups. When we discuss the patient, I tell my, and also I can easily tell my surgeon, listen, there's a short esophagus here. I can measure it with motility. That's very important. You cannot measure the endoscopy, the esophageal length well. In that case, my surgeons try to run away from Nissen, in patients with absent and even in ineffective peristalsis. Absent is very much debatable. If there is no peristalsis, should we still refer them to the surgery? This is debatable. But it's not absent but ineffective, yes. There is a consensus with TUPE. Second question, band ligation, I think is actually worse than the ARMA and ARMS, because bands immediately, we know from the varicose ligation, bands immediately run away, and very few stricture or fibrosis over there. I don't think it has a value. People try in Turkey without any scientific clue, they all give up. I never suggest to my team, we never do that.
Thanks, Professor Serhat, for an excellent presentation. I have a short question about LP, laryngopharyngeal reflux, confronted with increasing cases from ENT, and there is no gold standard for diagnosis. How you can deal with these patients?
Wow, thank you for the question. This is the worst scenario, LPR, because there are at least 18 different factors affecting the pharynx and larynx. A reflux is only one of those. We have a study showing that we put the pH catheter in, like all the others, we show that pH doesn't work. ENT's eyes never work, that's for sure. They sent the healthy volunteers to the ENTs, and 85% of patients come back at least with one LPR finding. Those are healthies. Okay, then what is the diagnosis? That's one problem. No, nearly all the PPI studies fail compared to the placebo. Now we have a disease, no diagnosis, no therapy. How to approach them? I believe there is a subgroup of LPR patients responding very well to PPI plus alginate. We use high dose of alginate, high double dose of PPI in those patients. We give them 3 months. If they're in that subgroup, if they respond, how lovely. If they don't respond, then I send them ENT back. And endoscopy, unfortunately, doesn't work, because endoscopy works about 30 to 40% of regular reflux patients. For LPR, it's only 15%. It has no value to performing endoscopy, which every day we have a lot of referral from ENTs. Oh, this guy has LPR, can you perform endoscopy? Generally we see nothing.
Dr. Serhat, this will be the last question. Thank you so much for this lecture. Actually, I would like to emphasize that the FDA, they approved only 3 routes of endoscopic treatment of GERD, which is TEF, Apollo stitch, over stitch, and the strata. Despite that, the ARMA and the ARMS, they are still the cheapest and the safest 2 maneuvers we can do in the endoscopic treatment of the GERD, but still they are not FDA approved until now. However, we are using it in the market, and they are raising a lot in the market. My question is about the eosinophilic esophagitis, because eosinophilic esophagitis, eosinophilic esophagitis.
Eosinophilic
Yes.
esophagitis. Yeah.
Yes, because I believe you mentioned that once we find any eosinophilia in the biopsy of the esophagus, we cannot proceed to such surgery. Is there a cut-off line or number that I can say this is not a hypereosinophilic syndrome, or I can proceed with this patient with this eosinophilia, or just once I found eosinophilia, I cannot proceed with this patient? Thank you.
Thank you. This is a very important question because esophagus of the patients with eosinophilic esophagus is so tiny. We can easily perforate it. Even during the routine endoscopy, I've seen a couple of patients perforated because endoscopists didn't realize that there is an EOE, push it, and then perforate it. You cannot perforate the esophagus in a normal healthy volunteer, normal human being. But those are very important. If patient has a dysphagia, we suggest take 4 biopsies, distal 4 biopsies proximal. If there are eosinophils, 15, then more than 15 in H high power field area, then this is practically EOE because also reflux comes with eosinophils, but should be less than 15. In that case, we start the therapy, and unfortunately, the only follow-up is pathology. We don't rely symptoms, we don't rely our eyes during the endoscopy, we just take the biopsies and the pathologists count the eosinophils and we understand the therapeutic response on those patients.
Thank you so much.
Simple question. You mentioned that 70% of patients with GERD are having a psychiatric background. Do you recommend giving?
Sorry, no. This is the population number.
Yes.
When you go to the streets.
So I think that the number is rising in patients with GERD.
Yeah,
Do you agree
absolutely.
with me? Yeah. So we recommend giving antipsychotics or pain modulators from the start with the PPI will affect the recurrence of symptoms after treatment. And second simple question, we have learned to diagnose hiatus hernia by endoscopy. You recommend now high resolution manometry for every patient suspected to have hiatus hernia?
Number 1, amitriptyline. A very recent publication came last week giving the amitriptyline the second layer for inpatient with IBS and found incredibly good results. I love amitriptyline, but it's not an antidepressant. It is neuromodulator. If you tell the patient, I'm giving you the antidepressant, patient will never take it. Whom I use it, not in the first level, but if I have a patient, difficulties to control the symptoms, I use it. That's for sure. 10 milligram only, wait 10 days, not respond 20, not respond 30. And I put the patient at least 3 months on the neuromodulators. SSRIs, unfortunately, not as good as tricyclics. This is why we should stick with tricyclics, not the SSRI. Question 2, yes, for sure, high resolution manometry even can detect 1 to 2 centimeters of hiatus hernia, which we cannot detect with the endoscopy. And this is why it's still the gold standard. Does it matter? Yes, sometimes it matters. Our problem is with the very big ones. We can easily misdiagnose the very big hiatus hernia with high resolution manometry.
Thank you.
Sorry, Dr. Yasser. Sorry, Dr. Gina. We have to close now because we are very much behind time. Thank you very much. See you. Now we call.